So related to this sort of audio podcast, I thought I'd provide an overview surrounding ADPKD, then highlight or provide an overview in regards to ADPKD versus ARPKD, and then some aspects relating to the pathogenesis and clinical management surrounding ADPKD. Some aspects are relating to the diagnoses and some sort of a basis around ADPKD complications in context of disease, around disease, and also around ADPKD disease progression. I would then provide a sort of a microbiology versus histology, histology or histological basis surrounding infections, infections surrounding ADPKD. Then I will be highlighting some aspects around the links between microbial infections and ADPKD disease progression, and I'll provide in this sort of audio podcast some overview around some clinical trials that have taken place surrounding ADPKD as well, and then finally provide a sort of a summary around this as well. So ADPKD, or autosomal dominant polycystic kidney disease, is perhaps one of the most frequent inherited disorders or diseases surrounding human physiology, and specific to the pathophysiology surrounding sort of renal physiology or renal around renal function. It's known to be, or has been evidenced as sort of the fourth leading cause of renal failure in the United States and perhaps more globally. In context of epidemiology, it affects ADPKD affects around 60,000 recipients in the United Kingdom, and it accounts for about 600,000 recipients in the United States, and around 10 million are affected or have been affected with ADPKD sort of globally. ADPKD affects one sort of in context of incidence and prevalence, if you like. ADPKD affects 1 per 400 to 1,000 people. About 7 in 10 patients or recipients with ADPKD progress into sort of renal disease, sort of more formally. The result of germline mutations are evident in around ADPKD, wherein PKD1 and PKD2 genes are affected, and these particular genes encoded for particular proteins known and referred to as polycystin 1 and polycystin 2. On here or in this sort of overview, I thought I'd take this opportunity to provide a sort of a basis between the differences really between autosomal dominant polycystic kidney disease and autosomal recessive polycystic kidney disease, or ARPKD. So in ADPKD, it's typically an adult onset in context of sort of predominance. The mutations are surround PKD1, and where there's sort of more than 80%, or around so where there's more than 80%, sort of from an evidence basis where PKD1 gene is affected, and around 15% or just over 15% where PKD2 genes are affected. Cystic kidneys. So in context of cystic kidneys relates to where the kidneys unfortunately apart from becoming sort of insufficient from an anatomical basis and a physiological basis. What also happens in cystic kidneys is cysts start to form as a basis or as a result of where the kidneys for example where usually where the toxins that are eliminated through urine or through voiding. What happens in cystic kidneys is the urine accumulates and in and around the kidneys. Unfortunately, cysts start to form as a result of this accumulation in and around the anatomy around the kidneys. So cystic kidneys, cystic kidneys, and all nephrons, all nephron levels, all nephron levels, but mainly distal regions are where sort of cysts become more sort of evident in ADPKD. The bile ducts and liver can also be potentially affected as a result of ADPKD as well. In sort of in children and young people, hypertension is evident in at least 20 to 40% of children and adolescents that are sort of that form part of a diagnosis from an hereditary perspective, and around 50 to 70% of patients or recipients can have issues around the sort of the renal insufficiency, where glomerular filtration rate decline when is evident, and there can be in autosomal dominant polycystic patients or recipients, there can be evidence of intracranial intracranial aneurysms as well, wherein more than 8% of recipients have sort of an increased threefold threefold of sort of evidence around where aneurysms excuse me, where aneurysms can sort of coexist as part of the ADPKD diagnoses, and in and around this also end-stage renal disease is evident in at least 50% of recipients by the time the recipients with ADPKD specifically reach for example 60 years of age. In and around autosomal recessive polycystic kidney disease is typically evident in sort of from a pediatrics onset, and the mutations exist around the PKHD1 gene and a DZIP1L gene as well. Cystic kidneys, for example, the collecting ducts and the distal tubules and the bile ducts are mainly affected. There can be hepatic fibrosis or scarring around the liver. There can be hypertension in around 75% of children or young people who are often during the first few months of life where diagnosis has been made. And intracranial aneurysms have been evident and have been documented in some case reports around Adpkd, and end-stage renal disease occurs in or is evident in 60% of recipients in 60% of ARPKD recipients by the age of 20 years of age. And so in context of in context of the pathogenesis, so here is a sort of a schematic that highlights the sort of the sort of the sort of the sort of cell signaling that takes place between sort of PKD1 and PKD2 genes sort of being switched on and off in context of cell signaling. But generally, due to mutations in PKD1 and PKD2 or PKD2 genes, a cell polarity, the cell signaling and cell polarity is affected, and there is sort of extracellular signaling that can cause more issues around the PKD1 and PKD2 sort of genetics in and around how these PKD genes are expressed throughout, and stimulation of cell proliferation through a mechanism involving intracellular signaling. So, for example, the sort of main cell signals include RAS, RAF, MEK, and ERK. In context of Adpkd complications, there can be complications by mechanisms, as well as where aligned with the mechanisms, there can be a sort of, or at least from a documented point of view or point of practice, the prevalence around particular mechanisms have been documented as well, and this sort of chart, if you like, provides a basis of the mechanisms by particular complications of Adpkd, and sort of where in sort of literature and particular sort of disease Adpkd sort of disease pathways, where evidence exists surrounding the sort of treatments available as well. So, for example, if recipients have a complication around where apart from the kidneys being affected, where there may be liver cysts or hepatic cysts evident as well. The mechanism around this can include increased where there's an increased cyst burden or impact, and typically coincides with an increasing age, and it's been evidenced in around 83 to 94% in context of prevalence, and there's 83 to 94 prevalence, and the available treatment for this is mainly one that relates to a sort of supportive treatment, and dependent on sort of the clinical sort of presentation around that particular sort of complication. And I won't highlight all of the Adpkd complications here, but listeners are welcome to have a look at the information at their own time. In context of Adpkd progression or disease progression, so mainly in the main laboratory or pathology monitoring includes sort of determining sort of creatinine clearance, and estimated glomerular filtration rate investigations to determine presence of fluid-filled cysts, and enlargement of sort of the of where there can be healthy kidney tissue that's been affected, and where and wherein from a pathology perspective, the total kidney volume, or TKV, is determined in that regard. And then progressive cyst formation and reduction of renal function generally leads to end-stage renal disease. But this schematic generally provides a sort of an overview in relating to sort of renal function, renal function, cyst development and enlargement, and a sort of almost sort of a comparison between a healthy renal tissue and where there's GFR decline by age. And so with increasing age, you can see that there from what would be sort of normal renal pathophysiology, then leads into hyperfiltration, impairment, and then failure or end-stage renal disease. And the schematic here sort of provides a sort of a basis from anything from anything from age 15 years up to 60 years. So generally, the schematic has can help sort of from can help clinicians and teams to sort of to ensure that recipients have a good sort of overview around sort of the Adpkd sort of disease progression. In context or in relating to sort of the pathophysiology and sort of microbiology aspects of Adpkd, the prevalence of urinary tract infections can be quite frequent and severe in Adpkd patients or recipients, and have been observed in around 3 to 50% of Adpkd patients, or up to 50% of Adpkd recipients. Cyst infection can lead to hospitalization, and evidence indicates in around 9% of Adpkd recipients, and wherein 20%, just over 20%, or just over 25%, where Adpkd recipients are on a form of renal replacement therapy known as hemodialysis, for example, have cyst infection, or can have cyst infection that leads into sort of formal hospitalization. Evidence also suggests that cyst infection is amongst the most crucial factors for Adpkd disease progression and decrease in renal and decrease in renal sort of anatomy and function. The issue of cyst infection has generally received sort of minimal attention across the literature in context of Adpkd, and the basis around this is not specific, but owing to the sort of etiology of Adpkd, generally generally it means that has meant really that the cyst and the infection aspects are sort of viewed as in ADPKD as a sort of a default, and so therefore generally receive a sort of minimal attention from a sort of from a sort of a clinical from a clinical perspective. E. coli, Klebsiella, and Enterococcus are perhaps some of the most causative agents in context of cyst development, or cyst not cyst development, in context of cyst infection. And the endotoxin of gram-negative bacteria has a role in the dysfunction of some other major organs, including renal anatomy as well. So the links between infections and ADPKD progression, additionally, is where there can be asymptomatic pyria and urinary tract infection that can have an impact on renal function in ADPKD recipients. Asymptomatic pyria has been observed in 1 in 3 of ADPKD recipients. There's an observed relationship or an association between UTIs, urinary tract infections, renal involvement, or renal insufficiency, and total kidney volume, aligned to PKD genetics. And ADPKD recipients with UTI tend to have a lower estimated glomerular filtration rate than those without urinary tract infections, and total kidney volume significantly has increased in ADPKD recipients sort of burdened or impacted with urinary tract infections versus ADPKD recipients without infections. And it can be the difference in total sort of kidney volume can be anything between sort of where at the higher end it can be 950 mils and 950 mils, and at the lower end 345 mils in relating to ADPKD and sort of infections aligned to with TKV. PKD1 mutations have been noted to be associated with increased total kidney volume, or TKV, in ADPKD recipients. There was a sort of proposed scope for work for the kidney disease improving global outcomes, or KDIGO, clinical practice guideline for the evaluation or management and treatment of ADPKD. However, the diagnostic criteria and methods of treatment options for cyst infection surrounding ADPKD are still not defined. Investigation of TKV in ADPKD recipients burdened with infections can help in sort of predicting around how best to provide ADPKD recipients support around sort of disease and disease progression, where recipients, ADPKD recipients, are also impacted with urinary tract infections as well. Here I thought I'd provide just a quick overview really around sort of clinical trials focused on ADPKD, and the overview here is, or at least the table on here is a little bit in depth. So I'm not going to read sort of refer to everything on here, but generally there are several clinical trials that have looked at ADPKD, and also the sort of interventions, the sort of treatment interventions aligned to particular clinical trials, and also basically where trialists where clinical trialists had sort of an endpoint classification in context of what align with the outcomes, with the sort of outcomes of clinical trials. They had an endpoint classification that linked to the different interventions, and then along with the sort of outcome measures, there was primary outcome measures and secondary outcome measures, and so typically for one particular clinical trial looked at the efficacy and safety of tolvaptan in subjects with CKD between late stage CKD, late stage CKD 2 to early stage 4 CKD stage 4, and where ADPKD is and was evident. And this was a clinical trial that was in phase 3, and tolvaptan versus a placebo was one of the interventions. The endpoint classification was looking at the efficacy around tolvaptan versus the placebo. And one of the outcome measures was, for example, to change the estimated glomerular filtration rate from before treatment to follow up. And then the secondary outcome measure was an annualized slope of EGFR, plasma tolvaptan, metabolite concentrations, and urinary osmolarity, urine specific gravity, to be sort of assessed and analyzed as part of the outcome outcome measures in this particular clinical trials. But as I said, the overview in this particular around these clinical trials are sort of a point of reference, and so most of these clinical trials have been in clinical trials phases 2 and 3, and obviously in here there are the clinical trials have particular identifiers as well. So as a point as a reference, listeners can sort of investigate should they want to identify what sort of where each particular clinical trial is, or whether it's sort of finished or been finalized, etc. So this sort of provides an overview around the sort of post enrollment clinical trials focused on ADPKD. So in summary, really, the formation of fluid-filled cysts are a hallmark of ADPKD, and the way the disease or disorder sort of devastates renal anatomy and in and around the extrarenal sort of anatomy and pathophysiology, and sort of manifests through sort of through the sort of throughout those who suffer with ADPKD. ADPKD is an important has an important genetic basis and cause surrounding CKD, and that should be considered in patients or recipients who are less than who are for example younger than 50 years of age, who present with onset hypertension and macroscopic hematuria and or impaired renal function. And a sort of a cure for ADPKD remains the sort of optimistic hope around the disease. Tolvaptan has been identified as a sort of one of the main pharmacological agents for ADPKD recipients, having been where in literature there has been some bases that highlight the delay in around TKV and renal insufficiency, and specifically there was a particular clinical trial that highlighted sort of positive results around tolvaptan, at least in literature before now. Cyst infection again is a common complication in ADPKD, and diagnostic criteria and methods of treatment options are limited and not always not clearly defined. Currently, fluoroquinolones are also are used, and they're sort of antibiotics of choice in treatment of particular cyst or cyst type infections, because owing to sort of the sort of intracystic penetration that fluoroquinolones provide in as sort of broad spectrum from a broad spectrum basis. And research around ADPKD research around ADPKD highlights that there is still a requirement for sort of more collaborative efforts in and around ADPKD and ARPKD.